So I'm going to be discussing my advanced respiratory assessment. So I would knock, come in the patient's room, sanitize, introduce myself. So hi, my name's Demi. I'll be the student nurse that's working with you today. Can you tell me your name and date of birth?
Jacob Chessa, 7798.
And then I'll just let them know I'm just going to do a quick respiratory assessment, listen to lungs, feel a few things, and ask a couple questions. So I'd start by asking if they have any history of any respiratory diseases or disorders, anything like COPD, bronchitis, asthma, lung cancer, anything like that. Asking if they have any family history of any of these things. And then ask them if they're having any symptoms today, so anything like coughing, wheezing, shortness of breath, trouble breathing, orthopnea, anything like that. And then I would ask them where they work, ask them what they do for a living. If they work in a foundry, nail salon, hair salon, a farm, they might be at an increased risk of having some issues because of the toxins and chemicals that they breathe in. I could ask them things like their diet, what they usually eat, if they smoke, if they hang around people who smoke because of secondhand smoke, if they vape, or if they hang around people that vape, again, kind of the secondhand smoke situation, if they exercise, and then I could ask them about medications, if they use things like inhalers, steroids, opioids, if they're up to date on their flu shot or their pneumonia vaccine, and things like that. So then I could go ahead and start my assessment. I would want to look at my patient, look at their skin color, notice any pallor or cyanosis, notice if there's any flaring of the nares when they're breathing, if they're a mouth breather or they have pursed lip breathing, if they're using their accessory muscles at all, if their chest is rising and falling symmetrically, that shows that both lungs are working properly, if they have any clubbing of their fingers, so I could have them put their finger together and see if I see the little diamond. Clubbing could be a sign of chronic hypoxia, and that comes along with COPD. Checking capillary refill to see if they have good perfusion, feeling their skin if it's warm, dry, things like that. And then checking if they have a barrel chest, which is another sign of COPD. So checking that. And then that's it. So then I could go ahead and have my patient turn and I could start palpating. So I'm going to palpate and I could have my patient say 99, 99, and feel the vibrations as I'm palpating, moving across the spots. And my patient would be saying 99. And then if there's an increased vibration, that could signify pneumonia. If there's a decrease, that could be something like a pneumothorax. And then if there's no vibration, that could be asthma or COPD. So then another thing I could do while my patient's in this position, oh, and I forgot to mention, that was called tactile fremitus, and now I'm going to be doing excursion. So for excursion, I would find the 10th intercostal, line my thumbs up, have my patient take a deep breath in, and then out. So as my patient breathes in, my thumbs kind of separate 1 to 2 inches, and then as my patient releases the air and breathes out, my thumbs come back together, so that's just showing both lungs are inflating and then deflating, and they're working properly. So then I can go ahead and start percussing. So for percussion, I just take my hand and tap 2 fingers on my knuckles. So when I'm percussing, I'm feeling for resonance, which would be normal. Any hyperresonance could be showing that there is a pneumothorax. Any dullness would be maybe there's fluid in the lungs, air in the lungs, things like that, excess air in the lungs. If it's flat, that could signal us and think maybe there's a tumor on their lung because it's kind of hitting against a solid surface when it shouldn't be. And then since my patient is in position like this, I could go ahead and auscultate. So I'd have my patient take a deep breath in and then let go out of their mouth. And I would just move as they're taking a deep breath in and then deep breath out of their mouth. And then I would go to all of my spots, doing the same thing, but for practice reasons, I'm just speeding it up a little bit. So they would be breathing in, out, in, and out. And then I could have my patient turn towards me. And I could do the same thing to the front side. So I could start by percussion. And then I'd go ahead and listen. So they'd be taking a deep breath in their nose and out their mouth. And I would keep doing that. Again, for practice reasons, I'm just speeding it up. Okay. So when I would be listening, I would be listening for bronchial lung sounds, and that would be up here. We would hear things that it would be higher pitched, and we would hear a shorter inspiration and longer expiration. And then when we have bronchiovesicular, that would be, we hear the expiration and inspiration are about the same. And then we have vesicular, and those are kind of lower, a little bit quieter, and your inspiration is a lot longer than your expiration. So then some abnormal breath sounds we could have would be crackles. We could hear crackles if our patient has heart failure. It just shows that there's fluid building up in their lungs, and you kind of hear popping. Another thing would be rhonchi. We hear rhonchi when our patient has bronchitis, and it kind of just sounds like a deep kind of rumble, I guess. And then the next one would be wheezing. You hear wheezing when your patient has asthma maybe, and it's just caused by the narrowing of the airway. It's kind of like a musical sound. And then our next one would be pleural rub, and this kind of sounds like leather rubbing against each other or two balloons rubbing on each other. And a cause of this would be pneumothorax, perhaps. And then our next one would be stridor. This could be caused by our patient choking on something. This one is an emergency situation, and we would want to make sure that we get whatever the obstruction is out. If our patient has diminished lung sounds or absent lung sounds, we really either it's very hard to hear them, or we can't hear them at all. This could be because of heart failure. We could have two things, and these are called bronchophony. And bronchophony would be, I have my patient and I'm listening, and I'm having my patient say 99. And when my patient is saying 99, if it's very clear and I can hear precise that they're saying 99, that's concerning, and that would show that they have bronchophony. And then the next one would be echophony, and that would be when I have my patient say E, and it kind of sounds distorted and almost like they're saying A. So those would be two concerning things.